Okay.
Good to start, ma'am.
Yeah. Okay, so hi everyone. So today we're going to talk on a very small topic again. So this is a very small micro teaching on germ cell tumors. Okay, so you have to understand this that whenever we classify the testicular tumors, we can either have germ cell tumors, we can have non-germinal tumors, and we have others. Okay, so germ cell tumors comprise approximately 95% of the testicular tumors, and in this, the most biggest category is seminomas. Okay, so seminomas are the biggest category that we have. Now, apart from seminomas, we also have spermatocytic tumors. Now, spermatocytic seminoma is called as spermatocytic tumors. And in non-spermatocytic tumor, the code is CETY. Okay, so CETY, that is choriocarcinoma, embryonal carcinoma, teratoma, and yolk sac tumor. So that point should be very, very clear to you. So it's very easy to understand it in this way that we have germ cell tumor. So today we're just going to classify about germ cell tumor. Majority of the germ cell tumors basically arise from germ cell neoplasia in situ. So there is always a in situ lesion which gave rise to germ cell neoplasia in situ, and this usually occurs after puberty. So therefore, any tumor which is prepubertal, like yolk sac tumor or teratoma, which are prepubertal tumors. So if they occur in a prepubertal age group, they are not associated with germ cell neoplasia in situ. So that is one point which you should be very, very clear. Okay. So yolk sac tumor and teratoma in the prepubertal age group are not associated with germ cell neoplasia in situ. Second, spermatocytic tumor is also not associated with germ cell neoplasia in situ because this also occurs in elderly after 60 years. So that is why these three tumors are not associated with germ cell neoplasia in situ. Otherwise, all the germ cell tumors are associated with an in situ lesion. Apart from that, most common mutation which is associated with germ cell tumor is isochromosome 12p. And this is one of the common mutation which is associated with majority of the germ cell tumor. So these are 2 pointers which everybody should be very, very clear. Okay. Now, once we're clear with this, today we're going to talk about just germ cell tumors. And in this category, first most important tumor is seminoma. What you need to remember in this, so seminoma is a germ cell tumor, arises from the germ cell neoplasia in situ. It usually arises in a middle-aged adult. Okay, so middle-aged adult. Please remember, most important point here, apart from isochromosome 12p, which is associated with all the germ cell tumors, especially, okay, c-KIT mutations is very, very common in seminoma. So that is one thing which you should be very, very clear. So KIT mutations are very commonly seen in seminoma. That's another point that you should be very clear. Now, if you look at the seminoma, that is typically characterized by its cut gross appearance is very, very typical. It is called as cut potato appearance. So just like you cut the potato and it is very homogeneous, that is how it looks like. And if you look at the tumor, it is arranged in lobules. Each individual cell is a polygonal cell like this, okay, which has a large nucleus and a prominent nuclei. So that is something which is very classical feature of the nucleus of the seminoma. And if you look at the septa, each septa is infiltrated by lymphocyte. So each septa is infiltrated by lymphocyte. So lymphocytic infiltration of the septa is very, very classical here. Okay, so septa is usually infiltrated by lymphocyte. So we have the lobules of the tumor cells, which are arranged by polygonal cells, which have large nucleus and prominent nuclei, and we have the septa which is infiltrated by lymphocytes. So these are the 2 points which you have to be very, very clear about seminoma, and its cut potato appearance. The prognosis is definitely good nowadays. Okay. Apart from that, you have to understand the seminoma. There is no definitive tumor marker for seminoma, but sometimes it can have syncytiotrophoblastic giant cells in this. So HCG can be positive in seminoma because of these syncytiotrophic giant cells. Okay. Otherwise, it is usually positive for PLAP. Okay. PLAP is usually a marker which can be seen in seminoma, but it can also be positive for HCG. So that's another point that you have to be very, very clear. So these are the pointers about seminoma that you should be very, very clear. Now, what are the new markers that have been discovered for seminoma? So seminomas are usually positive for NANOG. Okay, so NANOG, they are pluripotency marker. So that is always there. SOX17 is positive in seminoma. NANOG is positive. And of course, c-KIT is positive. So these are the markers which are typically present in seminoma. And that is what you have to be super clear with. Okay. Now coming to the choriocarcinoma. So the non-seminomatous tumor are CETY. So in choriocarcinoma, so they are Usually, choriocarcinoma is one testicular tumor which does not produce any lump. And if the lump is there, it is usually less than 2 centimeter. Remember, the most common presentation of any testicular tumor is a testicular lump, and here the testicular lump is absent. So that's very, very clear. Apart from that, you remember this is positive for syncytial trophoblasts and cytotrophoblasts. So it is positive for syncytial trophoblast and cytotrophoblast, and that point should be very, very clear here. And you should be clearly knowing that, okay? And it has large areas of necrosis. By the time you diagnose choriocarcinoma, it has already metastasized. So remember the tumor marker, which should always be covered here, it's HCG. HCG levels are very high. So any person who presents, even with a very small testicular lump, get a tumor marker done. If the HCG levels are high, think of choriocarcinoma, okay? Now, CE, embryonal carcinoma, no specific features. Just remember they are positive for SOX2 and CD30. That's a unique marker. Teratoma arises from the totipotent cells. So they will have all the totipotent cells. It will have teeth, sebum, hair, everything. Okay, nerve cells, everything will be there. Okay. So CET, and the next one is Y. So Y is yolk sac tumor. So yolk sac tumor is a tumor which is most common in children less than 2 years of age. And they are usually associated with very gelatinous tumors. If you look at this tumor, it typically shows you very special bodies. These are called as Schiller dual bodies, which resemble the fetal glomerulus. So there is a blood vessel in the center, which is lined by the epithelial cells, which is in a space which is lined by the flattened cells here. So that is what is called Schiller dual body. So this is a blood vessel. You can see these are the epithelial cells. This is a space in which this is present. Okay. So these bodies are Schiller dual bodies. Usually the yolk sac tumors usually have an excellent prognosis. So the prognosis of yolk sac tumor is excellent. Okay, so remember that is very typical of your testicular tumors, which you should remember. Remember, yolk sac tumors are easily identified with the help of a tumor marker, that is alpha fetoprotein. So alpha fetoprotein levels are very, very high in yolk sac tumor. So that's a beautiful testicular tumor marker which is seen in yolk sac tumor. So that's all, guys. So that is about your germ cell tumors of the testes. I hope everybody is clear. So what about the last germ cell tumor, that is a spermatocytic tumor? Remember, spermatocytic tumor usually occurs in elderly, and it has a very typical chromatin that you need to remember. It has a spireme chromatin, like a thread-like chromatin. That's a very unique chromatin which you should remember. So it has a spireme chromatin, and it also has a good prognosis. So I should not write excellent, but yes, it also has a good prognosis. Okay, so there's no unique point about it. That the only point is it does not arise from germ cell neoplasia and situ. Okay, so that's about germ cell tumors. I have most common in the middle age is your seminomas, which has lymphocytic infiltration, cut potato appearance. Then we have choriocarcinoma, which does not produce any lump, large necrosis. Embryonal doesn't have a unique feature. Teratoma has all the totipotent cell. While yolk sac has Schiller dual bodies and alpha proteins are very high, and spermatocytic tumor has pyrene chromatin. So these are the pointers about the germ cell tumors, which you should be super, super clear with, and that will always help you in making the correct diagnosis. Right, guys? Bye.